have a case that this is not an HIV case, but it's a MNA case still on treatment now. I saw this patient a few days ago, and I have several questions to give a poll in this meeting also. So prepare your smartphone for voting. And this is a Thai male case 61 years old, living in Bangkok. And 1 year ago, in 27th of November 2021, he visited our hospital. I call it hospital. Actually, the name is an institute, but it's a real hospital. He complained of a chronic productive cough, dysneurization, anorexia, and weight loss for 5 kilograms in 1 month. He didn't have any history of TB treatment or check up for the TB or X-ray before. Very strange, 61 years old, didn't have any history of treatment. But he insists that he didn't have any TB treatment before, and or contact any TB cases. And he had a history of smoking for 15 pack years and stopped smoking 15 years ago. And his X-ray is like this. Yeah. Imagine the X-ray, the extensive lesion like this, but didn't have any history of treatment before. He insists that no any treatment. And you can see that the extensive lesion, the large cavity at left upper lobe, bilateral fibro patchy infiltration. And everybody in this room say, oh, this is definitely tuberculosis. No argument. This is tuberculosis. But sputum examination show for smear negative 3 times, 3 days. It's morning sputum. And also the expert ultra. We did an expert ultra in every case. No MTB DNA detected. It's a negative result. HIV testing was negative. And in our hospital, we send a sputum culture and DST as a routine. And so in this case, what is your idea? X-ray, clinical sign, symptom X-ray, definitely tuberculosis, but smear negative, expert negative, expert ultra, not expert MTB RIF. For 4th generation, I told you this morning that ultra is very sensitive. So I want to get an idea from the floor that what do you think about this case? How to manage this case? F10. So I want you to vote which plan that you select to do in these patients. We have 15 seconds. Follow up and waiting for the culture result because everything's expert ultra, which is very sensitive, show negative result. Or start with the anti-TB because of extensive lesion and no history of treatment before. Oh, so everybody select to follow up the patients. But no one choose to treat the patient with the drug-resistant TB because of the extensive lesion. Do you think that the extensive lesion in the lung is a risk factor of drug-resistant TB or not? The history of treatment, yes. But if you have a new case with the extensive lesion, bilateral lesion like this, cavitary lesion like this is a risk of drug resistance or not? No. Everybody agree? Okay. So everybody, most of the people in this room selected to follow up them. But my colleagues said no. Because of the extensive lesion, we want to start the treatment because he didn't have any history of treatment before. We start with the drug susceptible, which is the second choice that most the people in this room selected. So we start the treatment. Oh, straightforward. Treat the patient with the HRZE. 7th of March 2022. That is about about 2 months after the treatment. At that visit, his sputum smear show 1+, AB 1+. And it's a 1+, this is likely to be the drug resistant. So we send it's a 1+, we'll send for the live probe assay, which is give you more information about isoniazid and rifampicin. But it's invalid, 1+ invalid. So is the possible cause of 1 plus in this case with the invalid result of a right probe assay? What is your idea? What is the cause of the 1 plus? F10. Okay, 15 seconds. Not comply to treatment, did not take the medication because we told the patient that you don't have any smear positive. It's likely to be from the clinical, but no proven. So most people in this room select to, let me see, I couldn't remember the answer. Treatment failure. And the second is non-tuberculous mycobacteria. It's likely to be non-tuberculous mycobacteria because right probe assay show invalid. Right probe assay is a test to prove that this is a TB first and then test the drug toxicity. So it's likely to be non-tuberculous mycobacteria. But anyway, for the non-tuberculous mycobacteria, we have to wait for the culture to confirm which strain or which mycobacteria. Treatment failure is possible, but is it too early or not? Because just 2 months, at the beginning is just negative. But in the WHO guidelines said that if you start with the smear negative or expert negative, and after that you have a positive result from smear or expert, it's likely to be failure. Because you started from the low number of bacteria, and with the treatment, the number of bacteria increased, so you have later you have a smear positive and expert positive. So that's under the treatment, the number of bacteria growing up. So it's likely to be failure. And non-compliance, even you use the video, we use a video dot, we cannot rely on the video dot, definitely, 100%. But because sometimes they show you the video, but actually in the mouth they didn't swallow the drugs. Is it that baseline? It's possible sometimes, but not in a short course. So what will we do? Our colleagues said that, okay, we continue the treatment. But later, we continue the treatment and okay, the CT scan, skip it because it's too complex. And so, but my colleagues told me that he decided to treat this patient not 6 months, but he would like to extend to 9 months because of the extensive lesion. And because the invalid result on March and with the high hand test is likely to be NTM, so he wait for the culture on 7th of March, and later up 2 months, I think it's in May or June, the culture at that time showed no growth of bacteria. So that is maybe the dead baseline at that time. And he continued treatment until 8th of August. He said that the patient said, okay, I'm very well now, less cough, less dyspnea. General condition quite good, weight gain for 5 or 6 kilograms. But at that time, we sent a sputum examination to follow up the result of the treatment, show 3+. That's 8 months after treatment. The same thing occurred again. The same condition, the same situation occurred again in March, 7th of March. So, and we sent the sputum for the live probe assay. It showed the isolated rifampicin resistant. Can we call this case as a primary TB, primary MDR or not? I think this is a primary MDR case because at the beginning we have already tested with the expert genotypic rapid molecular test, but show negative result. But now we can confirm that this is a MDR, and also we send for the second line live probe assay show the susceptible to fluoroquinolones. So go next. This is the X-ray. So, which regimen we use select to treat this patient? I told you this morning we have several regimen, but now we have a new 6-month regimen, the BPAR and BPAR. But in this case, that is 6 months ago. What do you think that? What is your idea? I mean, I should say like this: that in your country now, If you see a case like this, which regimen will you select to, or will you use to treat this patient? The question like that in your country or in your situation, which regimen will you use it? Depends on your programmatic recommendation. Okay. Bedaquiline-based shorter regimen. This morning I told you that we recommend to substitute prothionamide with the linezolid for 2 months, or the virtual individualized longer regimen, or BPAL or BPAM. Everybody select the virtual individualized longer regimen. We have the same idea. We have the same idea because in this case, it's extensive lesion. So the WHO guidelines said that in the case of extensive pulmonary lesion or extra pulmonary TB or extra pulmonary MDR, not recommend to use the shorter regimen because extensive lesion, no strong evidence to recommend the oral shorter or bedaquiline-based regimen in the extensive lesion. So everybody agree that using the longer regimen, but the pitfall longer regimen is that it's the most expensive regimen. In Thailand, costs about 300,000 baht per 18 months. 300,000 baht. That is 10,000 US dollar per course of 18 months. The most the cheapest is oral shorter bedaquiline based. So, but somebody still use the oral shorter or bedaquiline based. But why nobody use a BPAL-M or BPAL? The reason is that you don't have the pretomanid in your country. Simple question. Pretomanid sold by the Mylan, where there's a booth in front of this room. That company selling this pretomanid. And actually, the pretomanid now in Thailand, we are available since last August, and it's not very expensive. It costs about, per 6 months, it's about 350 US dollar, which is cheaper than the bedaquiline. So, agree to treat the patient with the longer regimen. For the WHO longer regimen, we select from the top to the bottom. We select levofloxacin. Why not moxiflox? Because the moxiflox causes more side effects than levoflox in our experience in Thailand. So we prefer to select levoflox. Another reason is that levofloxacin causes a prolonged QT syndrome or prolonged QT in the EKG less than moxifloxacin. And so we select the levofloxacin, bedaquiline, linezolid, and chlorpheniramine from the top to the bottom. And if you cannot use any drug, you select the next one. Okay. One point, the WHO recommendation in 2020 did not put pretomanid in the list. I don't know why, but why is the position of pretomanid in the WHO list? No one knows. When I asked an expert from the WHO, they said maybe on the group B. So that's why I put the pretomanid in the group B. Why not into the group A? He said that no strong evidence to put in the group A. Okay, that is a personal opinion. So pretomanid will be in the WHO list in the next publication maybe. So we select levofloxacin, bedaquiline, linezolid. Yes, we select bedaquiline 400 milligrams, linezolid 600 milligrams, chlorpheniramine, levofloxacin 750. CBC at the time is hemoglobin is 11.4, and everything seems to be okay. QTCF for 438 milliseconds. So we start the treatment, and surprise. After 2 weeks of treatment, we did the culture on September, 13th of September. In 13th September, smear negative, culture negative. So it means that the local regimen or the new regimen of the WHO is very strong in terms of eradication of the bacteria. So yes, AB negative, 13th of September, show negative result. And we continue the treatment. But 2 months after the treatment with this regimen, you can see that the drop of the hemoglobin from 11 to 9 to 0.2 is 2 gram percent. That's a lot. But I was under the prolonged QT. So we saw anemia in this case, 2 gram percent. So which drug that causes anemia in this case? F10, AK. What is the idea? Tick tock, tick tock. Oh, most of the people in this room selected linezolid and 7 selected. Go back. Beta queen. Linezolid cause myelosuppression, so cause anemia in this case. Beta-carotene didn't have any myelosuppressive effect, so beta-carotene did not cause anemia. Again, prolonged QT, 39 millisecond increase from baseline. Which drug caused this prolonged QT? Actually, in this case, you can select more one choice. All the drugs listing here cause prolonged QT. So we should be very careful to select the longer regimen because several drugs cause prolonged QT. You see? So that's why our Thai guideline, we select the levofloxacin in the longer regimen instead of moxiflox. Even we know that moxiflox is more potent than levofloxacin in the treatment of tuberculosis, drug-resistant tuberculosis, but we select. But all these drugs can cause a QT prolongation in the EKG. So, yes, everybody correct. Linezolid cause anemia. And usually, linezolid causes anemia after 1 or 2 months of treatment. So the side effect of linezolid we can predict from the time of treatment. So this is a practical point. So time point that you have to do the CBC is 1 or 2 months after. And if the patient did not develop the anemia or myelosuppression up to 2 months, you will not see any myelosuppression after that. So you have to wait for the next step of next adverse drug reaction. Prolonged QT can cause by many drugs. Okay. Go ahead. So we continue treatment. Everything is quite good. Smear negative, patient well, weight gain, QT not prolonged. But on 29 of November 2022, he attended the ER emergency room because of a marked dyspnea and weakness and nausea for a week. X-ray will show you later. But the CBC show hemoglobin 6.1. Actually, this case, we did something wrong in this case. At the time that we saw the hemoglobin of 9.2 gram percent, we have to reduce the dosage of linezolid from 600 milligrams to 300 milligrams. But because clinician at the time didn't notice the dropping of this, didn't aware that, so he continued the 600 milligrams. But at this time, he visited our emergency room and he was admitted to the intensive care unit. And at that time, you can see that the lactate, blood lactate went up very high, over 20 millimole. So this is a lactic acidosis. Which drug can cause a lactic acidosis? A well-known one is linezolid. So this patient is an example of lactic acidosis in the treatment of multi-drug resistance with the linezolid. In the literature, only 50 or 60 cases reported that lactic acidosis occur from the linezolid. Okay. Lactic acidosis, I don't have so much time, so I will go faster than So he was admitted to the intensive care unit and then treated with this regimen. And he was discharged from the hospital at 6th of December and continued with the chlorpheniramine, levofloxacin, cycloserine, betaquilin. We substitute as I showed you in the result, we substitute the linezolid with the cycloserine. And 3rd of January, that is 2 weeks ago, he attended our MDR-TB clinic and complained of numbness of both legs up to the mid of calf. What is the cause of this peripheral neuropathy? Which drug? I did not put the voting questions in the slide. So, is it betaquilin? Is it possible? No. Chlorpheniramine? Possible. Cycloserine? Well known. And cycloserine? No, not so much. Quinolone causes a peripheral neuropathy, which is a permanent damage. So we should be very careful about this. So if the patient receives the linezolid and levofloxacin or quinolone, and the patient complains of the peripheral neuropathy numbness, the first that I would like to stop is linezolid. I mean, that if you want to test it, is it caused by linezolid? But if you stop the linezolid, maybe you have to stop both and see whether the patients improve or not. If it improves, it's likely from the linezolid. I will show you this. Okay, this is a summary that I don't have time now. So in summary, the ADR, which is of interest in the second line drug, when you take care of the patient, you have to look for this adverse drug reaction. For betaquilin, we have to do the QT, EKG for determine the QTCF every month until we stop usually the prolonged, usually in the C209, C208 study, phase 2 study show that the patient who received the BDQ betaquilin have a 10 to 15 millisecond prolong in the EKG, in the QT. Myelosuppression from linezolid is well known, usually occur after 1 or 2 months of treatment. Peripheral neuropathy, 3 to 4 months, and optic neuritis. We have 10 to 15 cases of optic neuritis from linezolid in our institute. So we can predict the side effects from the timing that the patient had already received the linezolid. Chlorpheniramine skin discoloration is the most disturbing side effects to the patients, and levofloxacin, Achilles tendinitis. Don't forget this. We saw up to 8 or 10 cases now of the Achilles tendinitis, but no any case had the spontaneous rupture, but the Achilles tendinitis. Most in the moxifloxacin case. And peripheral neuropathy from levofloxacin or quinolone is a permanent damage, not a reversible. And cycloserine is a non-leukocytic. So this is a case that show the side effects from the treatment of the multi-drug resistant, even if it's not in the HIV patient. But if it's in the HIV patient, you have to be more aware of the side effect because of drug-drug interaction of anti-TB and the and ARV treatment. Thank you. Any questions?
Thank you, Dr. Charoen, for your experience sharing. So any comment or question from the audience? I have one question, Dr. Charoen. So when patients have myelosuppressed from linezolid 600 milligram per day, do you prefer to reduce to 300 milligram per day or 600 milligram alternate day? Is the first one. And the second question is, when you reduce the dose to lower dose, and do you re-challenge the full dose again after the myelosuppression is subsides?
No, we reduce to 300 milligrams and we use it 300 milligrams for the whole course of treatment. But one thing that we should know that in the animal study, linezolid for the MDR-TB treatment is not necessary to give for the whole 6 months. Linezolid benefit only the first 3 months of treatment. So it means that after 3 or 4 months of linezolid treatment, whatever the dose you use, 600 or 300 milligrams, if the patient experiences some side effect, you may be able to stop the linezolid after 4 months of treatment. Actually, in the BPAL study, 30% of the case stop linacid after 4 months of treatment, 33%. So it means that linacid not necessary to treat for the whole 6 months. So if you reduce to 700, we continue it. I will not increase to 600 milligram because it's not necessary, because the benefit is only on the first part of the treatment already.
That means if you stop linezolid in first, complete the first 4 months, you don't need to have any...
Re-challenge it, no.
Not re-challenge and do not need another
No.
drug to...
No.
Okay.
Yes.
Okay, thank you very much, Dr. Charoen.